Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Hello, my name is Scott Canna. I am a pediatric rheumatologist and associate professor at Children's Hospital in Philadelphia, and I am joined by my colleagues, Dr. Pui Lee.
I am Pui Lee. I'm a pediatric rheumatologist at Boston Children's Hospital, also assistant professor of pediatrics.
And by Dr. Ashish Kumar.
Hi, Ashish Kumar from Cincinnati Children's Hospital, professor of pediatrics and bone marrow transplanter and immunologist.
And so we are your experts for this conversations in interferon gamma-driven diseases, which is going to be a free-form conversation about what are considered to be, I guess, a relatively novel classification. We'll probably get into that a little bit later, since I'm going to be trying to stir up controversy. But in this first segment, we're really just going to talk about what, this collection of diseases are, and maybe a little bit about why they fall under perhaps an umbrella of interferon gamma-driven diseases. So we will just begin at the beginning. The learning objectives for this first topic, which is an overview of interferon gamma-driven diseases, are largely just to identify and differentiate clinical presentations of the various interferon gamma-driven diseases, including primary and secondary HLH and MAS. And if that sounds like a mouthful, it is, and we live through it. So where to begin? I think really, when we talk about interferon gamma-driven diseases, we are talking about what I colloquially refer to as the syndrome of HLH. And I think that that is a reasonable place to start. That's sort of where the criteria that we will discuss sort of kick in. But recognizing that this is a broad sort of swath of different diseases, and there's not clear dividing lines about what's in and what's not in that group. And so HLH, for the sort of truly new joining this, stands for hemophagocytic lymphohistiocytosis. And that name really has its origins in histopathology, like so much in medicine, especially in oncology. And I think, and I'm actually going to invite both of my colleagues to sort of weigh in here. I think that, perhaps HLH, we can be forgiven for calling it a lymphohistiocytosis because when you look in the lesions of patients with HLH, whether it's bone marrow or affected tissues, you see a lot of activated macrophage, you see a lot of histiocytes. But, I think the take home from at least what I plan to discuss is really that this is a T cell disease. And so, I'll invite Dr. Kumar and Dr. Lee to agree or disagree on, whether that is a reasonable central premise.
In general, if you're talking about HLH, the disease, that is a T cell disease. Now, the HLH syndrome, that gets people very confused. And so, especially if you start defining HLH syndrome by the clinical features, then that gets into the category that also includes the HLH syndrome and mimics of HLH that may have nothing to do with the T cell activation at all, yet they fulfill the diagnostic criteria of HLH. So we have to be very careful. But in general, the HLH disease, I completely agree, it is a T cell driven disease. The histologic features are, as our colleagues in pathology will call it, histiocytic hyperplasia associated with hemophagocytosis. That is the histiocytosis part of it. The lymphocytosis or the lymphocyte activation is not always histologically obvious. Dr. Lee?
I think I mostly agree. I think it's a T cell driven disease with lots of T cell activation in the picture. In rheumatology, we also call it macrophage activation syndrome, right? Especially when it occurs in the context of some of the chronic inflammatory diseases.
Sure.
in our world. And certainly there are many markers of macrophage activation in this condition. You can see like ferritins being elevated. You can see hemophagocytes, which are like in the marrow and other organs, where you see this big macrophage chewing up other blood cells. So it's a very telltale sign of this condition. So there's a camp that we think about myeloid cell activation as part of the cycle that drives this continuous cycle of inflammation. So T cells predominantly.
I think this is going to be a good precursor to later discussions, but maybe we're getting a little ahead of ourselves.
Yep.
So,
and I may dive into just to say that hemophagocytosis, that phenomenon, is not unique to this condition. You can actually see it in many, many conditions, many of which have nothing to do with HLH. So
we're going to cycle back
thinking,
to that.
yes, let's get back to that one later.
We have to tell our audience, what are we even talking about?
Yeah.
And so, and I think that, one of the things that I often say to trainees when they talk about HLH is I'll stop them and I say, well, are you talking about HLH or are you talking about HLH? Yeah. And Dr. Kumar hinted at this. If we're talking about the syndrome of HLH or the mechanistic sort of etiology-based disease of what is probably more properly called primary HLH. So, what even is the syndrome of HLH? Well, first of all, I think it's important to understand that the syndrome of HLH is temporal. It is not, something that someone necessarily has forever, but it is an immunophysiologic sort of state in time. And it has certain features, and each of those features are sort of read out in different, clinical or lab findings. And so, maybe the most obvious feature almost goes without saying, but is worth saying, systemic inflammation. This is a systemic inflammatory or hyperinflammatory disease. And how do we read that out? We read that out as fever. Often the fevers are sort of hectic, don't necessarily have a temporal pattern. And then, the other features of systemic inflammation really are fairly nonspecific. Things like CRP elevation, LDH rise, any of these sort of acute phase reactants that you might usually expect with a severe, high magnitude systemic inflammation, with some caveats that I'll touch on briefly, but I think Dr. Lee is going to talk more about in the biomarker sort of section. But we can't sort of glance past hyperferritinemia as sort of one of the sort of foundational aspects of this, a really high ferritin. And we will talk about how ferritin is not by itself a specific biomarker, but it is probably a pretty sensitive biomarker, meaning if you've got someone with inflammation, but they have a normal or near normal ferritin, you're probably not dealing with someone who is in or approaching the syndrome of HLH. But that's not enough by itself. I think the features of disseminated intravascular coagulation are another sort of facet of this syndrome, and that can be read out in a number of different ways. The reason I didn't mention an elevated sedimentation rate as an inflammatory marker that you might associate with HLH is because what drives the sedimentation rate elevation in most people is actually fibrinogen. But if you're in DIC, you're consuming fibrinogen. And so, a dropping or abnormally normal sedimentation rate can be a sign of DIC and can go hand in hand with HLH. But fibrinogen itself is a thing that should be measured, as well as obviously a platelet count that is inappropriately low, and clotting factors like, your coagulation, PT, PTT, and even a D-dimer, which again is quite sensitive, not specific for sure, but it's very hard to say that someone has any significant DIC with a normal D-dimer. So we've got systemic inflammation, we've got high ferritins, we've got some features of DIC. We have hepatosplenomegaly or organomegaly, maybe specifically of reticular endothelial organs like the liver and spleen. And how do we read that out? Well, by exam, maybe by imaging. I certainly think that these big livers and especially spleens are contributors to the low platelets we see in a lot of these patients because they kind of gobble up those cells. And cytopenias is another sort of feature of this. I think in the criteria, which we'll discuss, we sort of lump the cytopenias together. but at least I think of the mechanisms that drive neutropenia as often being quite different than those that drive anemia and thrombocytopenia. The neutropenia is probably a bit of cytokines like interferon gamma inhibiting production of neutrophils, maybe the spleen sequestering a little bit, but I mostly think of it as a sort of lack of neutrophil sort of hyperproduction or activation, maybe some consumption. The platelets we talked about, sequestered, consumed, and likewise, anemia is probably mostly just acute inflammation, inflammatory disease. Maybe, a little hemophagocytosis, but that's controversial. So inflammation, ferritin, cytopenias, DIC, likes to involve liver and spleen, and to that end, hepatitis. Liver dysfunction, elevation of inflammatory markers, or of liver function markers, sometimes also with like elevated bilirubins, and probably elevated triglycerides, at least in my opinion, is likely a readout of liver dysfunction. And then I would throw in CNS dysfunction as another part of this syndrome, if only to really put it at the forefront of people's minds, because in a very sick patient, often their mentation or maybe more subtle findings of CNS involvement, mild meningitis or things like that might get missed, and they're not things that you would want to miss in HLH. So that syndrome that we've described, which probably everyone on this call has observed in some patient somewhere or another, usually in the ICU, is together what we consistently call the syndrome of HLH. Now, I'm going to mention that there's criteria, and then maybe I'll ask maybe I'll throw this. So Dr. Lee's a rheumatologist. Dr. Kumar is an oncologist. So the various criteria, and by the criteria I mean there's the HLH-04 criteria, which were sort of revisited recently, and really largely unchanged, except for maybe dropping one of the criteria, which is the NK cell cytotoxicity assay. But there's also macrophage activation syndrome criteria. And as Dr. Lee mentioned, macrophage activation syndrome is the name that we often give to the syndrome of HLH in a patient with an underlying rheumatic disease. And then there are other criteria like the H score or the HS score. There's a variety of these. So Dr. Lee, tell me, why do the MAS criteria differ from the HLH criteria, and why do we need different ones?
Yeah, I think it provides more context, right? So we see MAS in rheumatology mainly in the context of systemic driven idiopathic arthritis, sometimes spring lupus, and sometimes we see in monogenic autoinflammatory diseases as well. In children with systemic JIA, which is where we see it the most, they have a lot of inflammation at baseline, right? So the marker, I guess the diagnostic criteria in MAS in the context of systemic JA has to take into account that you have baseline inflammation, chronic inflammation, or even active inflammation in a lot of these children. And the sort of disease is somewhat different. The tempo of disease is somewhat different compared to, let's say, primary HLH. The onset is usually later. It often depends on the disease activity of the underlying rheumatic disease itself. So I think these different criteria in some ways tailor towards the individual disease for the single field of rheumatology, for example, which we're more apt to recognize this in children with systemic GIA compared to some of the other diseases, for example.
So would you say that those criteria help you differentiate in a given patient who has the diagnosis of systemic onset GIA, have they reached MAS? Would that
Correct.
be more the right application of those criteria?
Yeah.
Okay. The challenge we often face is the patient is in front of us, has never been diagnosed with anything before. Now what do you do? And I think most of our colleagues are in that situation. And based on our experience, at least historically, people are still using in the hematology oncology world. Now that also applies to who's being consulted and which lens are they applying. If the ICU consults the rheumatology team first, they may be more apt to call it MAS. If they consult the hem-onc team, they may be more apt to call it HLH.
Right.
And I will be honest with you that many of my colleagues in Hem-Onc don't even know what MAS is, how it differs from HLH, from primary HLH, let's put it this way. And the HLH 2004 criteria, 2004 was 20 years ago. And back then, our knowledge of this syndrome, of these variety of diseases, was in its infancy. I would argue even now we are just beginning to unravel and understand. But at least 20 years ago, there was only one gene that we knew of in primary HLH. Okay, and now we know almost all of them. There's about, depending on where you draw the line of whether it is an HLH gene or not, at least 15 different genes that we know bona fide will qualify as causing primary HLH. And we understand the biologic mechanisms. And we also understand that those criteria that were set out by pioneers in the field when there was nothing else to go on, they came up with criteria that were readily available to identify these patients who would otherwise go undiagnosed and eventually die of a disease that people could not recognize. So they were extremely valuable in saving lives, but now we understand that they're actually quite nonspecific.
Correct. I think one of the general feature of these diagnostic criteria is that it favors on the side of sensitivity, right? So we don't miss these cases.
Yeah.
For example, in the systemic GIA criteria, we have a cutoff of 684 for ferritin, right? Which is, we can see lots of patients without systemic GIA, right? So not specific by any means, but it is sort of catch our attention and start thinking about this process.
Right. And all the lab values and all the definitions of systemic inflammation that Dr. Canna mentioned, majority of them are the outcomes of the systemic inflammation, not not markers of what's driving the inflammation, except perhaps ferritin gives us a clue that macrophages are activated. None of them are specific for T cell activation, which in all forms of true HLH, you must have T cell activation. And so we need markers of T cell activation, which I'm sure he's going to get into next.
Well, I noticed you used the term true HLH. And so I think it's worth a digression into, we've now talked about the syndrome of HLH, and we've hinted at the number of different ways that you can get there. And so to my point earlier about when I'm being sort of glib and asking a trainee, is it HLH or do you mean HLH? What I mean is, are you now referring to the syndrome of HLH, or are you referring to a mechanism associated with most of the causes of primary HLH? And we often conflate one with the other.
Yep.
But that, for reasons that I think we all agree with, is a bit dangerous. So, there's primary HLH, which is constituted of familial HLH, which familial HLH is a term that I think really should be reserved for, the 5 or 6 different genetic causes of granule-mediated cytotoxicity failure.
Agreed.
So if you lack perforin or you lack a bunch of genes important for granule function, you're going to get to HLH. And boy, I would love to geek out about this, but in short, it's basically because granule-mediated cytotoxicity, the things CTLs and NK cells do, is an anti-inflammatory process. It shuts down T cell activation by killing the target cell.
Yep.
So that's familial HLH. There's other forms of primary HLH which don't have the name familial because they have other syndromic features like Griscelli syndrome and Hermansky blood type 2. And these are also cytotoxicity granule-mediated defects. Now, there's other maybe arguable forms of primary HLH that are not granule defects. Some of them are even kind of autoinflammatory diseases like NLRC4, but they're genetic diseases and arguably primary HLH. And then outside of that, you have this vast world of secondary HLH. And I think that, one of the key points that I try to point out is that even in primary HLH, there's almost always more than one contributor. Now, our patients with perforin deficiency, almost all of them are born looking okay, and it's not until they get some sort of infectious trigger, usually, often we don't even know what it is, that they tip into this sort of, severe HLH phenotype. In MAS, the majority of patients, all of whom have some rheumatic disease, usually Still's or systemic JA, some lupus, many of them are triggered by infection. In infection-associated HLH, there may be patients that have other contributors, whether it's an immunodeficiency or a partial cytotoxicity defect. And then in malignancy-associated HLH, that's a really mixed bag.
But even if I could interrupt, when you
Please.
say infection-associated HLH, are you saying infections that fulfill the criteria?
I think that this is a reasonable area of debate, is most of the patients who are classified as infection-associated HLH have EBV. And EBV HLH is a well-recognized thing. It is often severe. It's more common in Asian nations for reasons that are not entirely clear. And not most patients with EBV HLH don't have a genetic susceptibility. A few do.
So again, sorry to interrupt, but I think this is an important piece, that EBV HLH is a separate category of diseases. I would argue that you cannot lump that as infection-associated HLH. The main reason, because we know in the Asian populations, as you mentioned, actually it's Asian and native Central and South American, where they actually have EBV infection of NK cells and T cells, which is different than the rest of the world, where EBV infects the B cells, causing a limited infectious mononucleosis. But when EBV enters T or NK cells, it can actually cause a unrestricted lymphoproliferation of those T and NK cells, and that is unable to be controlled by the normal immune system, and that is why you end up getting the syndrome of HLH, because it is truly hyperinflammatory. What I'm trying to get at is that there are many other systemic disseminated infections, the ones that we have seen, herpes simplex adenovirus, and there are many other bacterial, and actually in infants who get histoplasmosis, they all fulfill the criteria. But the difference that I'm trying to get at is that in primary HLH, in MAS, in other forms of true secondary HLH, there is a maladaptive activation of T cells. And that is then starts the cascade of macrophage activation and all the other inflammatory sequelae that we see. And so the main driver of the disease, the pathology in all of these, is that it's the maladaptive inflammation. Contrast that with many other disseminated infections, not EBV, where it's the disseminated infection that is causing the immune system to ramp up in response to that infection, but it fulfills the criteria. Now, in that situation, turning off the immune system, adding immune suppression, actually is detrimental. Now, these criteria, they unfortunately do not allow us to differentiate between, is this systemic inflammation proportionate in response to a disseminated infection versus maladaptive or ectopic in magnitude because of an immune dysregulation. I don't think we have a straightforward way of telling those apart, and that is what gets us into trouble.
Yeah, certainly. I agree. I mean, there's a thin line there, right? Because, for example, influenza, right? You also have this massive, cytokine burden that contributes mortality, and it's sort of both ways, right? There's inflammation that you need to overcome the infection, and then there's a fine line between that and overwhelming immune activation that causes an HLH phenotype. Yeah.
Correct, but we must still at least look for an infection. So in influenza, we know, but the challenge we many times see that due to the dissemination of the warnings about this disease that should not be missed, people are desperate to start immune suppression without looking for infections, without looking for an underlying malignancy that could be the driver. You absolutely can have both things present. and which creates even more confusion. But if we want to draw, separate boxes, there is the primary HLH, the genetic, then there is the non-genetic, but still immune dysregulation where the actual pathology, the disease pathology, is driven by unregulated activation or maladaptive activation of the immune system. And then this third category where we don't know whether immune suppression actually is going to be helpful or not. It is truly, there's an underlying trigger that you must search, and you cannot ignore that. And if you don't do it, then that's where we run into trouble. Sorry, Scott, took over.
I'm going to wrap this section up. I know that we will pick up this thread later. I think that Dr. Kumar and I have a slightly different perspective on the utility of the term infection-associated HLH, even outside of EBV. But I think we're all in agreement that regardless of the source, that the syndrome of HLH has some characteristic features that include what I've described, some biomarkers of T cell activation that we are soon to talk about, and a signature that really is sort of redolent of that T cell activation producing excessive interferon gamma, but that there are two aspects. There's treating the syndrome of HLH, which often involves somewhat nonspecific anti-inflammatory treatment. But more importantly, there's the identification and the elimination of the driving contributors. And if those are infections, the necessity is to identify and treat that infection. So with that, I'm going to close section 1. I'm going to thank Drs. Lee and Kumar, who will be back in section 2.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.